Our last speaker of this session is also hails from Case Western and came along with Chris Polcheski's group. And this is Tim Kern, and as they said in the Monty Python, and now for something completely different, Tim is going to tell us about low-intensity light to prevent reverse diabetic retinopathy. Thanks, Tim.
Okay, thanks very much to the organizers for giving me the opportunity to talk. I'm going to go into what a very internationally regarded biochemist regarded as, well, basically, after I gave a seminar on this, he came up to me and he said, "I love the data. It smells like voodoo." So that's the warning. So what I'm talking about using is low intensity light to, or photobiomodulation to exert a biological response. This is independent of wavelength, although most people have been using the, let's say, from the green, wavelengths of like 500 and up into the infrared region, because UV has detrimental effects on lots of cells. The important thing that I'm going to be talking about, that this is not laser. Lasers have been used for many years by ophthalmologists and others as a surgical cutting tool or to burn tissues. This is like looking at a flashlight. It's being used heavily in sports medicine to repair muscle injuries, things like that. But it is now being picked up by lots of different other branches of medicine. So I'm going to talk about it in the context of diabetic retinopathy. Diabetic retinopathy is currently diagnosed and regarded as a vascular disease, and in particular, this is where you basically inject a fluorescent dye into the bloodstream, and you can see areas where there's hot spots, and that's leaky blood vessels or new blood vessels growing. But you can also see areas where there's, it's much darker. And in fact, there is no blood flow through these areas at all. So one of the things that we're trying to do is identify ways that we can inhibit the degeneration of the blood vessels in the retina and the leakiness of the blood vessels in the retina. So this is our presumed schematic of what diabetic retinopathy is and how it develops. An alteration in blood sugar causes a variety of metabolic abnormalities, and these are not necessarily only in the retina. We have some pretty clear evidence that white blood cells are participating in the development of the vascular lesions of diabetic retinopathy. But then you get abnormalities that do eventually cause visual impairment in diabetic patients. And the most notable are the neovascularization that happens in the vitreous, the retinal thickening or the retinal edema. There is also a neural dysfunction, but we don't really have, that doesn't cause blindness, but it does alter the quality of the vision. So what I'm going to talk about again is using photobiomodulation on its effects on the retina in diabetes. The wavelength I'm going to be talking about primarily is here 670 or 660. So it is visible, but it is near infrared. It's low intensity. It's less than a joule at the surface of the eye. We administer it every day, but it's only administered for 3 to 4 minutes per day. So any of the effects that I'm showing you right now are only from 3 to 4 minutes per day. Going straight to the end of the punchline of the whole thing, this is a quantitation of the capillary degeneration that I showed you from the prior picture. And basically in non-diabetic animals with no treatment, there are a small number of degenerate capillaries. Everybody in this room has them. In diabetes, this is 8 months duration of diabetes. In diabetes, there is a significant increase in the number of these degenerate capillaries. But in diabetic animals, treated with light for 4 minutes a day, the capillary degeneration is very significantly inhibited. Importantly, we all know that bright light can cause retinal degeneration. And this is just a measure of the thickness of the outer nuclear layer. The light therapy is basically indistinguishable from the animals that did not get the light therapy. So this is not causing any undesirable effects on the retina. These studies are done in mice too, so the mice don't like to look at the light. So this is not a direct effect of the light. With regard to the diabetes-induced increase in vascular permeability, which has been well characterized, the retina has 3 different layers of blood vessels in the inner plexiform layer, internuclear layer, and the outer plexiform layer. And so the data here shows that the untreated diabetes causes an increase in permeability in each of these areas, and the light therapy significantly inhibits in every one of those areas. Again, that's only 3 to 4 minutes a day. That's actually 4 minutes a day. Mice are not known for the quality of their vision, but nevertheless, the processes, the biochemical processes are the same. And so the evidence here is that spatial frequency threshold is the mouse equivalent of visual acuity. This is the standard contrast sensitivity. And in both cases, diabetes of 2 months or 8 months duration significantly inhibited the visual function, and light therapy totally prevented that in the diabetic animals. So question is, and this comes back to the voodoo. How does this happen? We don't know. Right now, the data that we have, it looks like light therapy is acting like aspirin. It's doing pretty much everything. Here is leukostasis, the white blood cell adhering to the blood vessels of the retina. Here is ICAM expression. So the 2 of these are markers of inflammation occurring in the retina. Retinal superoxide production. This is oxidative stress and ganglion cell loss. But in each case, you can see diabetes, untreated diabetes, causes a significant increase, and the light therapy very significantly inhibits this process. If you give the light therapy every day with regard to the superoxide, there is a total prevention. If you give it every other day, the effect is only half as good. The interesting thing is, though, we put a lead shield over the animal's head. So what we have basically is a tanning bed for mice. And we put a lead shield over their head so that the eye could not have any direct contact from the light. But what you can see here is the superoxide, again the controls, normal, diabetes significantly increased, light therapy to the whole body, including the eyes, had a significant effect. The lead shield over the head had no significant effect on the beneficial effect. So it looks like it's a systemic effect of the light therapy. It need not be a direct application to the eye. Again, this is the white blood cell adherence. There was, the effect, if the lead shield is put over the head, is variable. So here's white blood cell adhesion. There was not as great of a demonstrable effect. A couple other things. Here's ICAM expression in the retina. Here's INOS expression. The effect of the head shield was, again, not very marked in for ICAM, but in the light there, in the INOS expression, there was no different. It just wasn't as good as in the case where there was no adverse effects, no beneficial or adverse effects of the shield over the head. So basically, the overall impression from this is that the light therapy or photobiomodulation applied to the whole body has beneficial effects on the eye in diabetic animals. So what happens if we do this to people? So we did a small case series. Another group since then has done the exact same small case series and came to identical conclusions, but we did 670 nanometers, and it was 3 minutes a day. So 1.5 minutes in the morning, 1.5 minutes in the evening, every day. The patients keep their eyes closed. This does not require them to keep their eyes open at all. So here is OCT to assess retinal thickness. Basically, green and yellow is normal. The thicker the retina, the more abnormal the retina becomes, the more orange or red it becomes. And these patients were all selected because they had non-center involved diabetic macular edema. And so this is the eye before treatment. This is the exact same eye after treatment for a number of months. Some of these patients, we couldn't get the device back from them, and they wouldn't come back in because they thought it was doing a lot of good. So the fellow eye, there was basically no beneficial effect seen whatsoever. So this seems to be a localized effect. Now, what I'm telling you this time is different than what I told you before. Before, the beneficial effects of light therapy were exerted systemically. This is a light therapy that is held up directly to a patient's eye, and so it's having a local effect as well. We're still trying to figure out how to interpret that, but there are both local and systemic effects of this light therapy, it seems. So the light, photobiomodulation applied directly to the eye also seems to work. And based on this data, basically the National Institutes of Health, the Diabetic Retinopathy Complications Clinical Research Network has instituted a multi-center clinical trial to confirm and further investigate the beneficial effects in diabetic retinopathy. So again, coming back to the presumed mechanism by which the diabetic retinopathy develops, the light therapy seems to have inhibited critical steps in each one of these different processes. So the question, another question then is the beneficial effect of light therapy unique to one wavelength, and is it unique to the eye? So this is some data that we have that are generating now. So basically this is oxidative stress in the kidney. This is, we have evidence that leukocytes taken from a diabetic patient or a diabetic animal, if placed on endothelial cells, the leukocytes from a diabetic will kill endothelial cells more than the leukocytes from a non-diabetic patient. So what happens if you give them the light therapy? We selected a whole series of different wavelengths. So 505 is green, 595, 660, this is the wavelength that I've been showing you before, and then 730, 810, and 880. These are getting into the infrared range. This therapy is applied for 4 minutes a day. It is, every one of the wavelengths are given at an intensity of 1 joule per square centimeter at the surface of the eye. And basically, it's not just the red wavelength, it's many of the different wavelengths, but it seems to vary. The beneficial effect of the light seems to vary between one parameter and another. So the evidence is that this light therapy has beneficial effects also in other tissues affected by diabetes. So the potential benefits of this therapeutic option are, it's very easy to administer. There's a low treatment burden. There are no known side effects. It's readily available. It's cheap and could possibly have a high impact. Question is, can you go to the beach and claim you're doing the same thing on a sunny day? And so we have actually made calculations measuring the intensity of light in the animal room where these studies were conducted, and found out how many joules of light were coming in the light, in the reduced light in these animal rooms over a 24-hour period, or 12-hour, because it was 12-hour on, 12-hour off, versus 3 to 4 minutes under this LED. The joules of 670 light that's coming in is almost identical between the animal facility and the high intensity light that we're giving over a period of 3 to 4 minutes. So there is some sort of an intensity function. You have to cross a threshold before this has a beneficial effect. You can't just average the whole thing over the whole day. The interesting thing now is that this light therapy is becoming available in a whole different variety of ways. You watch television at 4 o'clock in the morning, you can see light therapy will do remarkable things. But there's really scientific evidence that this light therapy is having beneficial effects on a whole variety of different things. One of the big problems of this area of photobiomodulation is that companies jumped into it too fast and were making ridiculous claims about what light therapy could do. These are all validated scientific studies that have been done within the last 4 or 5 years, which are trying to reintroduce hard science into the whole process. So I really do think there is something there. We don't know how this works. And there are a variety of hypotheses, but the prevailing hypothesis right now is that the light therapy is directly interacting with cytochrome oxidase in the electron transport system to stimulate ATP production. We have looked at all of those via a variety of different methods with regard to diabetes in the retina, and that hypothesis does not work in this system. So we are continuing to investigate lots of other things. I'd like to acknowledge all the people who would participate in this way. Thank you much. Basically, this was we called them every week to make sure they were continuing to do it. But the study, we had intended the study go on for 6 months, and it ended, the patients didn't come back for 7 to 9 months, basically what it was. And so we only have the before and after. The other study that was done in Milwaukee, basically, they had measurements at two different time points, and the edema was resolving slowly. It is not, it's not like the anti-VEGFs where you give the therapy and there's a beneficial effect in a short period of time. This is a slow and gradual process. So for that reason, I'm not really advocating this as a primary course of therapy. What I hope it would turn out to be is like an adjunct therapy that would perhaps slow down the frequency with which you need to get the anti-VEGF therapies or something like that. Yeah, we've done a lot of those studies in a whole variety of different animals and in humans, but in a human, you can identify pericytes readily. In a dog, you can identify pericytes readily. In a monkey, you can identify pericytes readily. In a rat, you can get a good idea. In a mouse, it's impossible to confidently identify pericytes in about 25 to 50% of the cases, so I don't even bother to measure it anymore. So the issue with flicker, we started to do work in that area, and we got away from it because of the possibility that someone might have, get seizures from it. So we did not pursue that. But we are looking at multi-wavelength, combination therapies right now. The frequency at which the the light is delivered, it looks like it, in our data, it looks like the therapy has to be administered daily to have the maximal effect. The action spectrum data that I just showed you, it shows that it is not one wavelength. Whether or not multiple wavelengths applied together will have beneficial effects, don't know right now. Just wanted to point out that there is a study that was just released in the last year or two, the Torpo study for dry AMD, and basically they used photobiomodulation, and what they did is they used 3 different wavelengths, the 670 and 590 and 790 all together, and they administered it only 3 times a week for 3 weeks, and then looked 3 months later or a year later, and we're finding a beneficial effect on reduction in size of drusen and in contrast sensitivity and ERG. Well, the issue is that if you look at the amount of, for example, 670 that is in the, in the sunlight that you would get at a beach, it's there's about 1,000-fold more of the 670 nanometer intensity in this light therapy than you would get, during a 2-hour period out on the beach. So people, in fact, Ron Klein and others have looked for the regional distribution in the severity of retinopathy, and to the best of my knowledge, nobody's found one that is reproducible.